I want to show you within the next minutes what we did within the last years, or what changed within the last years in our department, the improvements of treatment, the improvements of results, and are based on the data that we have from our patients treated since many years. So if you look on prostate cancer treatment in Austria, we have about 14 departments in Austria to perform radiotherapy, and this is a slide with a huge database for all the departments, 14 departments in Austria, and about, just to remind you, about 30% of patients with primary prostate cancer receive radiotherapy. And about 700 patients per year in Austria receive salvage radiotherapy. So the total number of patients in the whole Austria is about 2,100 patients per year with prostate cancer in primary or postoperative setting to receive a radiotherapy. Within our department, the numbers have changed as well. If you look at the year 2010, we had about 190 patients receiving radiotherapy. That's the blue column. And the last year, we had about more than 250 patients. Meanwhile, we did also change our treatment technique. The advanced treatment techniques, such as brachytherapy or VMET or IMED, the percentage did increase from 28% in the year 2010 to 95% in the last year. So nowadays, nearly every patient with prostate cancer gets a highly advanced treatment. You already know, and it's already said before, you can divide prostate cancer into 3 risk groups: low risk, intermediate risk, and high risk, according to PSA, tumor stage, and Gleason score. All these patients have in common that because they are localized with no signs of lymph nodes or metastasis. And according to these risk groups, we can recommend the patients different treatment options in radiotherapy. In the low-risk group, the patient might receive external beam radiotherapy, or called teletherapy, or as brachytherapy. We do perform a seeds brachytherapy in our department. These patients are not candidates to have additional hormonal therapy. The intermediate risk group we divide into two groups, a favorable one according to the Roche formula. These patients can go for teletherapy and as well brachytherapy. And the unfavorable risk group with a Roche formula above 50% goes for teletherapy or a combined treatment, tele-brachytherapy. And these patients are recommended to have a hormonal therapy for 6 months in total. And at the very last, the high-risk group can either go for teletherapy or as well a combined tele-brachytherapy, recommended hormonal therapy for 24 to 36 months. So the seeds brachytherapy is a minimal invasive treatment, ultrasound guided, where you place the seeds into the prostate. It takes about 2 hours in total under ultrasound guidance, and the patient is about 3 days in the hospital. The external beam radiotherapy is ambulant treatment, and we did see, and there was a big change in the treatment techniques within the last years, within the last decades. When I started as a doctor, we did perform a 4 field box technique, and now we are doing a VMAT technique, so we have nowadays an improved geometry regarding the isodoses around the treatment volume, and this offers the potential of a dose escalation. On the right side you see a picture of IMRT, intensity modulated radiotherapy. That means that allows to spare the dose at the organs at risk, rectum and bladder. And nowadays we are doing so-called volumetric arc therapy. That means that the gantry is rotating around the patient, and meanwhile the radiation is performed. And this results in an even more improved geometry regarding the treatment volume. As well, we are doing an image-guided radiotherapy. Patients have gold markers implanted before the radiotherapy to have a more and improved accuracy in daily patient positioning, and to reduce the safety margin, and as well to reduce the side effects. Or we can perform a cone beam CT during radiotherapy. So what did change by these better treatment techniques was an increase of dose. We started with a dose of 66 Gray, increased the dose to 70 to 74 Gray, then for all patients to 74 Gray, later on 78 Gray, and local, and 78 Gray local plus pelvic radiotherapy in high-risk patients. And now that was with conventional fractionation, 2 Gray per day. So that was about 39 fractions for the 78 Gray group. Nowadays we changed into hyperfractionation. We reduce our fractionation about 30 fractions only, with an increased daily dose, and with a biological dose of about 81 Gray for low and intermediate risk group patients, and 83 Gray for intermediate and high risk patients. And I will show you later on the results of the 66 to 78 Gray patients. All the patients we are treating, we are seeing at least once per year after treatment to have the result and to document the side effects as well as the PSA. We have about 3,700 patients in our database, about 2,400 patients with primary localized prostate cancer, and about 1,700 patients with risk group definition available and T-stage available. And I'm reporting now, give you the results out of these 1,700 patients. So to remember, 66 Gray, that was the oldest group, so that is, has the group with a longer follow-up, 185 patients included, 209 patients in the 70 Gray group, 600 patients, 74, more than 300 patients in the 78 Gray group, and the seeds brachytherapy, it's also more than 300 patients, with different follow-ups, of course. Regarding the risk group distribution, about 1/3 of patients belonging to the low risk group, about 40% to the intermediate risk, and 1/4 to the high risk group of patients. Let's start with the side effects. Our goal was to increase the dose and to improve our results without increasing the side effects, or at least without having a high increase of side effects. If we talk about side effects, we have to divide gastrointestinal, rectal, and urogenital side effects according to the EOTC score. You can divide into grade 0 to grade 4 side effects. Grade 0 means none side effects at all. Grade 1 means moderate changes after radiotherapy, no medication necessary. Grade 2 means medication necessary, grade or signs of blood or mucus in the stool or increased frequency. Grade 3 means surgical intervention or severe dysuria, for example. And grade 4 means fistula, perforation, or necrosis. So the main and severe side effects are, in my opinion, grade 3 and grade 4 side effects. And if we look about the rates of grade 3 and 4 side effects, according to the different dose levels that we applied, the rate after 5 years, the cumulative incidence is at a very low level at about 3%. Even in the 78 group, it's just 3% after 5 years. It's a little bit higher compared to the 66 grade group, of course, for the rectal side effects. And if you go for the urogenital side effects, there was a slight increase. If you compare 66 grade to 78 grade, it's about 8% incidence rate after 5 years for grade 3 or more side effects. However, it's at a very low level. And the treatment results according to the different risk groups in our department. We did improve our results in the low risk group patients after 5 years from 75% biochemical control up to date now to close to 98% in our patients. So it was a tremendous increase for the low risk group by increasing the dose, as well an increase for the intermediate risk from 54% for the 66 grade group up to 84% now for the 78 grade group, an increase of about 30% around. And for the high risk group as well, an increase, an improvement of treatment technique due to the dose escalation from 50% for the 66 grade group up to 70-80% nowadays for the high risk group. Biochemical control rate after 5 years. So in conclusion, radiotherapy is a treatment option for all primary prostate cancer patients, regardless of risk group. It's a treatment option showing comparable results to surgery. It's non-invasive or just minimal invasive, and it's a treatment option with a low rate of severe side effects. Thank you.